Maybe some of you don't have to imagine as much as others, but you're at home and you get a phone call, and it's an old friend, and the old friend says, hey, let's go to dinner and let's go to a movie. And you miss the old friend. You hadn't seen him in a long time, but you're terrified. Because you know to go to the movie and to go to dinner is going to put you at risk. It's going to put you in a position where possibly you might be embarrassed. Because it's been so long that you've been able to go out and be with friends and be with family and go to a restaurant, go to a movie, go see your grandkids or your kids play a sporting event. Because you know that there's a risk that you might have an accident. And you know that if you go, there's a very high likelihood that you might end up being embarrassed. And you have to decide, is it worth going or not? Is it worth rolling the dice to have this evening with friends and take the risk of having an accident? So you decide, you know what? Tonight is dance recitals. My grandkids, when they ask me. And maybe they think I'm just not interested. Maybe they don't know there's fear that you might have an accident and that you might be embarrassed. But you decide to go after all of that. So you go to dinner, you make it through dinner. You're coming here. Imagine this is the old Roxy. We're having a movie here tonight, and you're coming to this movie. And you come in that back door. And from the moment you walk in, you're like a spy on reconnaissance. Where's the bathroom? You walk in the back door. You can't even spend the time to talk to your friends, to talk to your family, because you got to find the bathroom. Where's the bathroom? I come in the back door. Let's see, the bathrooms are to the left. Let me go over here. Not only do you have to find the bathroom, what if you get to the bathroom and there's only one bathroom and somebody's in it? So you got to spy out, what's my situation here? Is there more than one? So you go to the bathroom, you open the door. Oh my gosh, okay, at the Roxy there's 3. We're good. But then you come in this back door. And again, maybe your family's talking to you. How was your evening? How was your dinner? But you can't concentrate because you have to decide, where am I going to sit? Where am I going to sit to get to the bathroom the quickest? That I'm not going to be embarrassed, because you know at some point your brain is saying, how long is this going to last? It's a 2-hour movie. I'm going to have to go to the bathroom maybe twice. Can I get out? You walk in. And when you walk in, I can just imagine when you walk in and you look for the seats, are all the seats on the outside full? Am I going to have to go past somebody? And then if I have to go to the bathroom, am I going to have to get up and get around them? You're just praying as you come in, can I find a seat that I can sit in that's on the aisle? And is it close enough that I can get to the bathroom if I have to? Do I have enough time? So how can you live your life? How can you find enjoyment in your life when every decision is based upon, can I get to the bathroom? I can't imagine. I can't imagine the fear that people face going out and thinking, I don't know if I can sit through a basketball game. I don't know if I can sit through a dance recital. I don't know if I want to sit through a dance recital. I might be acting like I got to go to the bathroom. But what kind of fear they have to put up with? And so many people decide, you know what, it's not worth it. I'm not going to go because I'm afraid of what might happen. See, it's not like back pain or knee pain that you can fight through. If you're at a public event and you have an accident, it's humiliation. And how can you deal with that? But here's the crazy thing. 1 in 6 Americans deal with urinary incontinence. 1 in 6. 42 million Americans. That's the decision they have to make anytime somebody calls them. Can I do this? Can I live my life? Can I do the things I want to do? 42 million. 1 in 12 deal with fecal incontinence. 21 million people have that fear every day. What about in Muskogee? Muskogee County, there's 66,000 people. 11,000 people in Muskogee County deal with urinary incontinence. 6,000 people in the city of Muskogee deal with urinary incontinence. But here's the crazy thing. People are scared to talk about it because it's embarrassing. You know, the studies show that 50% of patients who have urinary incontinence or fecal incontinence will not talk about it with their doctor. They won't talk about it. 50%. So of those 42 million people in the United States that have this issue, 21 million won't even mention it to their doctor. They'll go to their doctor, however frequently they go, for any reason they go, but they will not mention it. Because they're embarrassed. Or, we were talking earlier, sometimes maybe you mentioned it to your doctor, but your doctor doesn't know how to treat it. Or doesn't really want to deal with it. So you mention it one time, you're already embarrassed. Why would you ever mention it again? And then it becomes ingrained that I'm not even going to talk to my doctor about it. So you suffer in silence. And you live a life that's of less potential and of less opportunity because you're afraid to talk about it. Because you just think there's no answers. Here's what I want to tell you. My whole mission in life is this: to search for and capture every opportunity to ignite and empower people to endeavor to maximize their limitless potential. I'm here tonight to tell you there is an answer. There is ways around this to allow you to live a life where you can reach your maximum potential, where you can reach the potential with your family, you can do the things you want to do, you can live the life you want to live, because urinary incontinence should not stop you. Don't ever think it's a natural part of life. That's false. Just because I'm getting older, I'm going to get urinary incontinence. That's false. Just because I'm a woman, I'm going to get urinary incontinence. False. Just because I'm a man, I'm going to have prostate problems, I'm going to get urinary incontinence. False. There are ways to treat it, and that's what we're here tonight to talk about. So, first of all, if you don't know me, my name is Dr. Jack Weaver. This is Oscar, my man. Let me get my clicker. Where'd you put my clicker, Chance? This is Chance, my charge d'affaires. Okay, Oscar's going to shake your sound. There we go. Now we're talking. So, I'm Dr. Jack Weaver. Now, sometimes you might ask yourself, why am I talking about urinary incontinence? Why is Dr. Weaver talking about urinary incontinence? Because I'm a pain doctor. But let me tell you my background. I did a family medicine residency, Lansing, Michigan, 1993. And so I was a family practice doctor. When I came out, I decided to specialize in musculoskeletal medicine and the management of pain, back pain, knee pain, sports injuries, those type things. And as a result of that, I started doing procedures where I implanted electrodes in the spinal canal. And because that kind of merges with one of the technologies we're going to talk about, I started doing treatment of urinary incontinence. And now I am blessed with 5 wonderful nurse practitioners who do family medicine. So in our group, in our family medicine group, we have 5 family practice nurse practitioners. We've got Dr. Elgin, who's here tonight, who's been a family practice doctor for a couple of years. We won't mention. And we got Dr. Ryan Pitts, who he and I did the same thing, the same pathway, and Dr. Pitts is practicing in Fort Gibson right now. So we have a whole group that now we do a lot of different disorders. So one of the things that we do now is this treatment of urinary incontinence. So that's why we're here. That's why I'm here. And I told you that there's good news. There are ways to treat this. Now, I want to start right now showing you a video that is a patient who had urinary incontinence that was affecting her life in a dramatic way. And she had this treatment that one of the treatments we're going to talk about tonight, and it has completely changed the way she lives. So let's watch Sarah's story. This is about 5 minutes. Again, this is a real patient that had this Medtronics therapy.
My name is Sarah, and I'm a management consultant, and I'm 28 years old.
Hi, good morning, Sarah. You have some missed calls.
It's a lot of work, and I'm very much engaged in my career and where I'm going, and it's just very exciting right now. When I was about 17, I started noticing more frequency and the urgency coming on, and dealt with it through various forms of antibiotics and just different approaches with diet. And then it got worse and worse. I was really embarrassed when I first joined this company that I had this to deal with, and I actually called it bladderitis. I would get into work and attend a meeting, and again, you find sitting down the minute that you stand up. Kind of embarrassing when you've got clients around and you've got a high table in the ladies' room. You just always felt like you had to go. It just was not good. It was horrible. So how I was led up to InterStem was through a physician referral that this was the last hope, basically, that I had. And I went in very skeptical, very reluctant, and very closed to this final idea.
The thing I remember most about Sarah is when she came to see me, she was miserable, first of all. She had tried numerous therapies. Everywhere she went, she was being ruled by her bladder symptom that was controlling her, was affecting her relationships. She is a professional who travels a lot. It was affecting her work. And when I saw her, she was essentially at the end of her rope. The best thing with Sarah, I remember, is when I talked to her about the InterStem, she was so skeptical.
I didn't understand why she was so sure that it would work, but given the high percentage rate, I was very open towards the end of our conversation. Given that there was a trial, I was very secure with the fact that it wasn't going to be permanent, that we could have that trial period. My test stimulation period was interesting. It involved a lot of different changes to my settings to try to figure out which one was going to work, and nothing seemed to be doing the trick until the day before the end of my trial, which was a great success for me because it took a little bit of time to settle in. So after the success of the trial, I decided to go ahead and have the second surgery for the implant, and have had no problems since. I love to run and was only really able to run short distances. Any movement to the bladder was just, would set you off with regards to feeling like you had to go to the bathroom. After InterStem, it's like I never had that problem before. I could stay at the gym as long as I want, and I even ran a half marathon just because I didn't have to deal with that anymore. I think of all of the things I am most proud of that moment. 2 hours and 28 minutes and 13.1 miles in 20-degree weather. I did it because of InterStem. I don't think I could have done it without it.
So one of the things I want you to realize when you listen to Sarah's story was one of the first things she said. She was 17 years old. So it's not a disease of age. It can happen to anybody, and it completely disrupted her life. And as a result, it made it where she couldn't function She couldn't do the things she wanted to do. She couldn't do the things she loved to do. And it disrupted her lifestyle completely. She couldn't live her potential. So when we talk about urinary incontinence or fecal incontinence, let's look at a couple of things. I've already told you some of this. 50% of people with urinary incontinence will not talk to their doctor about it. When you think about that, it's so crazy. Something that completely disrupts your life, completely disrupts the quality of your life, but you're embarrassed to talk about it. And it's mind-numbing. People ask the question, will I ever regain control? Can I attend an outdoor celebration? Can I get a job? I'm afraid to leave home. I've talked to people before that just never leave their home. They have this therapy, and it completely changes their life. I always think about the vast majority of people I see are people with back pain, knee pain, and it affects your life. But you can work through that. You can kind of tough your way through those type of pains. But if you can't control your bladder, if you can't control your bowel, you can't go outside. It changes everything. I can't even imagine being in fear every time I'm going out anywhere. Being afraid, can I make it to the bathroom? But that's what we're dealing with. Bowel and bladder issues are not inevitable. They're not something that everybody's going to get. They're not a normal process of aging. And that's something we have to kind of get over and think, it's just a normal process of aging. That's what's going to happen. I just have to put up with it. This is the stat I gave you earlier when I was talking. 1 in 6 adults in the United States, 43 million people have urinary incontinence. 21 million people have fecal incontinence. It's a huge number, and it's a daunting problem. But there is good news, and we're going to talk about that tonight. So the first thing I'm going to do is I'm going to tell you a little bit about what we mean when we say urinary incontinence, because it's a little different for everybody. There's different types of urinary incontinence. There's not just one type of urinary incontinence. And depending upon the type you have and how it affects you, the treatments are different for these things. So, first thing to talk about is what causes these issues. There's a list of things that causes these issues, but I kind of like to think, I like stuff that I can remember in my mind easy. So when I'm talking about bowel and bladder problems, I think of the 4 F's. Food, fitness, pharmacy, I know that's a PH, but it sounds like an F, and facts of life. So let's think about it. Food. When somebody has urinary or fecal incontinence, the things that you take in affect you. If you're going to go to a movie, if you're going to go to dinner, or you're going to go somewhere, you're constantly thinking about what can I eat, what can I drink, right? But there are things that we eat and drink that's going to cause us to have accidents if we have urinary incontinence. And we have to think about the way we eat and the things we drink, the food that we intake. The other thing that a lot of people don't think about with urinary incontinence is that obesity causes urinary incontinence. It puts extra pressure on your pelvic organs, and that can lead to urinary incontinence. So what you take in affects the bowel and affects the bladder. Food, fitness. People that are more fit, that are able to have stronger core muscles, that have stronger pelvic girdle muscles, that are not overweight, are far less likely to have bowel and bladder issues. And if they do have bowel and bladder issues, they're far easier to control. So what you do, your activity level has a significant effect on that. Pharmacy. One of the big culprits of bowel and bladder problems is drugs that we take. We take all kinds of drugs. We show up at a doctor's office, we have a problem, we throw a medicine at you. And these medicines are not benign. So sometimes the medicines that we take can cause urinary incontinence. And if that's causing urinary incontinence, that's a simple fix. So it's not a matter of just walking in saying, I've got urinary incontinence. We got to figure out what's causing it. Facts of life, the 4F. Things like childbirth, surgeries, radiation to treat cancer, things that happen to us in our life, things that affect our body can cause bowel and bladder problems. So there's a number of things that can cause them. Here's the crazy thing about the bowel and the bladder. It is a delicate interplay between your brain and your bladder and your bowel. to keep everything functioning in order. I want you to think about a baby. Think about a baby when it's born. This baby has constant urinary incontinence, right? It has no control over its bladder or its bowel. Have you ever wondered why? Is it just because they're dumb? They haven't been learned yet? They haven't been taught yet? See, here's what happens in a baby. The baby's bladder starts to fill up, and the nerves in the bladder muscle, when they sense that the bladder is filling up, they send a signal towards the spinal cord. But in the baby, there's a reflex mechanism that sends a signal immediately back to the bladder that says, you need to empty. Or immediately back to the bowel that says, you need to empty. And they do. And it's socially acceptable, right? Nobody cares if a baby has an accident, except the person that has to change the diaper. It's just kind of a fun thing, right? It's just what they do. And we make, oh, you would poo-poo, good for you. That's what happens, right? But it's a whole lot different when you're 17, or when you're 37, or when you're 77. So why does it happen then, and why should it not happen? So here's what happens as a child. As we grow, and we get to that age where we start to get potty trained, the same neural mechanisms work. The bladder starts to fill up. Why? Because we take food in, we take drinks in. The kidneys filter out the toxins, and they form a substance that's called urine, a liquid, that runs down into the kidney, that runs down into the bladder, and the bladder starts to fill up. Your bladder is a muscle. And your bladder has receptors in it that sense stretch, or that sense volume. So as that muscle starts to stretch, it starts to send signals to your brain that is starting to fill up. But see, as we get older, we develop the ability to adjust those signals a little bit. We don't just have this reflex mechanism. We think, I'm up on stage. My bladder starts to stretch a little bit. It sends a signal to my brain, your bladder is starting to fill up. But then there are areas in my brain that kind of filter through this. And we don't fully understand completely. There's about 6 different areas in the brain that get these impulses, and they think, okay, Jack, you're up on stage. You're in the front of a number of people. It probably wouldn't be a good idea to let your bladder empty right now. So my brain tells me that. And my brain sends a signal to my bladder, and my bladder won't empty. And time goes on. And you're sitting at a basketball game in the middle of a whole big group of people, and you get a signal that says, hey, your bladder is filling up. And your brain says, okay, we're at a basketball game. It's kind of difficult to get to the bathroom. Where's the bathroom? Should I go or should I stay? I think that was an old song. Should I stay or should I go? Or something like that. And you have to decide logically, is this a boring part of the game? Is Dak Prescott getting ready to throw an interception and I'll be happy if I go to the bathroom? And you decide, am I going to go? But it's a conscious decision, an interplay between your brain and your bladder. And if you finally decide, I'm going to go, you get up, you walk to the bathroom, you get to the bathroom, your brain tells your bladder, here I am, and your bladder empties, and you go to the bathroom. And that's how it's supposed to work. But sometimes it doesn't work that way. Sometimes the signals get mixed up. Sometimes it's a problem with the bladder. Sometimes it's a problem with the nerves. Sometimes it's a problem with the brain. But when the signals get mixed up, then you have an accident. And it's not always under your control. But there's this interplay with the brain and the bladder that we don't always think about. It's the same thing with the bowels. When the bowels start to fill up and the waste gets all the way to your rectum, it starts to stretch, and the same interplay goes on. Should I go now? Do I have time? Am I okay to stay a little bit longer? There's 10 minutes left in the movie. I should be good. Your brain plays into that. And so this brain-bladder communication keeps you safe, keeps you out of harm's way from embarrassment. But if something goes wrong, that's when we have a problem. There's 3 common types of bladder problems: stress incontinence, urinary retention, and overactive bladder. Stress incontinence is what happens when you laugh and you get a little leakage of urine. Here's the thing I always think about when I take a stress incontinence. Who's seen Pretty Woman? Have y'all seen Pretty Woman? Do you remember in Pretty Woman where Julia Roberts is at the opera and she gets so excited about the opera and she's getting ready to leave and the little lady sitting next to her says, "Honey, did you like the opera?" And she said, "I liked it so much I almost peed my pants." And the lady's like, "What?" And Richard Gere says, "She said she likes it as much as the Pirates of Penzance." But that's stress incontinence. That's your bladder is full and something happens. Somebody tells a joke and you laugh and a little bit leaks, right? Or, like Sarah, you want to go for a run, but when you're running and you're bouncing and you're going like this, maybe you get a little leakage in the bladder. Anything that causes stress, maybe it's laughing, maybe it's a sneeze, maybe it's a cough, maybe it's bending, maybe it's lifting, maybe it's climbing stairs, maybe it's just standing up. But you know that you're at risk of having an accident. And maybe it's a little bit of leakage, maybe it's a lot of leakage, but you know that you're in danger. So you never go to a comedy club because you're going to be in big time trouble, right? You don't go exercise. Sarah couldn't go run a marathon or a half marathon because you're in constant fear that something is going to happen and you could be embarrassed. That's stress incontinence. Then there's urinary retention. Urinary retention is usually something that is blocking the bladder from emptying. The bladder fills with urine, but there's something blocking it. And so it keeps building pressure and keeps building pressure. And eventually there's leakage at a time when you don't want leakage because of the pressure built up behind it. You can't tell that your bladder is full. You go to the bathroom and you try to empty your bladder, but you can't fully empty it, so you go back to sit down and you've still got a full bladder. And this is common in people that have some sort of an obstruction. It's common in men who have prostate problems. The prostate gets enlarged, it closes down the urethra, and they can't empty the bladder. And so it gets to a point where there's so much pressure built up, eventually they're going to have leakage, and they're going to have an accident. Some of these people get to the point where they can't empty their bladder and they have to use a catheter. That's urinary retention. And usually it's because of some sort of physiologic blockage. But the one that we're really interested in is what's called overactive bladder. Overactive bladder can be broken down in different categories. One of the categories is called urge incontinence. And what overactive bladder means is your bladder is filling up. And if you think of the bladder as a muscle, and so it's this muscle that fills up like a balloon, and when it's time to go to the bathroom, the muscle contracts and it squeezes down and it pushes the urine out the balloon into the urethra and out. So there's a muscle that contracts, but there's also a muscle that closes up the outflow tract. So there's this interplay, right? When your bladder is filling up, and I'm up here speaking in front of you guys, my muscle that's holding my bladder closed is firing and not letting any urine out. And the muscle of the bladder is relaxed. And the bladder can fill up. And as it fills up, it starts to stretch and it starts to give these signals, hey, I'm starting to fill up. And when it's time to go to the bathroom, the muscle that blocks up the bladder relaxes and the bladder muscle contracts and it squeezes out the urine. So both areas have to work together. The brain has to say, this one's got to close, this one's got to relax. And if anything causes a disruption between those two, you're going to have a problem. And that's what urge incontinence is. You feel like you have the urge to go, and all of a sudden you feel that urge, but you know what? The signals didn't get there in time. Or the signals were just bombarding, and you decide, I gotta go to the bathroom, and you jump up from your seat and you start to go, but before you can get to the bathroom, the bladder contracts, and the sphincter muscle relaxes, and you have an accident. It wasn't caused by laughing, wasn't caused by stress, it's caused by a lack of communication and overactive muscles. That's urge incontinence. These people have frequent leaks. It happens so many times. And it's not a normal situation. And it's not stress incontinence. It may happen after drinking a small amount of liquid that shouldn't be enough to do it. It may be just from hearing or touching running water. That cracks me up for some reason because I've never had that issue. But if I turn on water around my wife when she's got to go, it makes her go to the bathroom. It's like the weirdest thing. I can't figure it out. But that's urge incontinence. Please don't tell her I said that. Is this live stream?
Yeah.
Okay. I always get myself in trouble. These people end up using a lot of pads or garments because they know they're going to leak. And they know it's going to happen so quickly they can't control it. That's urge incontinence. Urge frequency is when you have this constant, uncontrollable urge to go. It's always there. And these people have multiple accidents a day. Maybe they have to go to the bathroom 8, 9, 10 times a day. Because there's just always this urge to go, and that muscle is just like, it's like a spasm. It's like hyperactive. It's constantly contracting because it's getting abnormal signals. And because of those abnormal signals, it's constantly pushing. And at some point, the muscle that closes the bladder is going to let go a little bit, and it's going to have some leakage of urine. These are the type of things, this overactive bladder, are the ones that really are the easiest to treat and are the most effectively treated with one of the therapies that we're going to talk about tonight. Fecal incontinence is a similar thing. Fecal incontinence is not quite as common. It's 1 in 12. There's the same interplay with the brain and the bowel. But for some reason, in people, you're not getting that communication right. And it can be due to nerve injuries. It can be due to trauma to the muscles that control the contractions in the intestines. It can be due to injuries to the pelvic floor. But fecal incontinence is the same type of deal. You may not even feel the urge to go, and all of a sudden there's leakage. Maybe it's small amounts. A lot of people with fecal incontinence, they don't have huge big accidents, but they have these small leakages multiple times through the day, happening constantly. They constantly have to plan activities around the bathroom. Constantly have to know exactly where the bathroom is. Do I have enough time to make it? Do I have enough space to get there? Do I need to wear an undergarment? Do I need to wear something that controls, that helps protect me? That's fecal incontinence. So, what do we do? How do we treat these things? If there's treatment for it, and I'm telling you that 50% of people don't want to ask about it, but I'm also telling you there's hope. There's the ability to live your life fully and not have to deal with it. So what do? Well, there's a number of different treatments, and most of the time, the first step in the treatment is to go to the doctor and say, hey, I have this issue. I leak urine. I have accidents. And then your doctor should then spend the time to sit down with you and take a history and say, well, tell me about that. Because we need to know, is it stress incontinence? If you say, oh man, every time I laugh or bend or try to run, I have a little leakage. That's a whole different deal than overactive bladder. Or is it that, I don't know why, but I have to go to the bathroom like 10 times a day? You learn that through history. And so your doctor should be taking a good history. What is going on? It's not just one thing. It's not just everything's the same. There's different things that cause it, just like we talked about. So that should be step one. The second step should be a physical exam. Is there something that caused it? Or a history that caused it? Somebody that comes in and says, well, I had cancer and I've had chemotherapy, and ever since I had chemotherapy, or ever since I had radiation, I've had incontinence. Right? That history, we can pick out a lot of things from that. So once we do the history, once we do the exam, once we look at this and say, here's what the cause is, there are different treatments. And usually the first step in the treatment is medications. Almost always, that's what you're going to be treated with first, because sometimes the medications work. And there are different groups of medications. The most common group of medications are what are called anticholinergics. And what anticholinergics do is they basically allow the bladder to relax and not be constantly contracting. So if you think about this bladder, there's these constant stimulation. When you take an anticholinergic drug, which there's a whole list of them, what it does is it blocks receptors on the bladder muscle, so it's not constantly being bombarded by impulses to make it contract. And so it just kind of relaxes it. So somebody that has an overactive bladder, if they take anticholinergic medications, then they're going to relax that bladder. But just like with any other medications, there's side effects. So anticholinergics almost always cause dry mouth, they cause dry eyes, they cause a lot of different side effects for people, and so the vast majority of people that take these anticholinergic medicines that initially work for them, they quit taking them because of the side effects. So they have to decide between having the bladder control or having all these side effects. And after a period of time, they just decide, you know what, I can't deal with the side effects because it's just not perfect for that. You're using a drug that really is meant for something else to try to control this. There's another class of medication that basically relaxes the smooth muscles. And it works pretty well at relaxing the smooth muscle, but you got to take it all the time to relax the smooth muscle. And anybody that has blood pressure problems or cardiac problems, it affects the heart. So there's this interplay. Is it safe to take? Or are you going to have side effects from it? Is it going to lower your blood pressure? So there are medications, and most people always are on medications first, but the vast majority, 4 months in, have stopped their medications because of the side effects. So it's not perfect. That's oral medications. I skipped lifestyle changes. Here's why I skipped lifestyle changes. I did it on purpose. You know why? Because you guys always skip lifestyle changes. I was wearing a shirt today that I had my daughter make, and it said, "What would you do to live better?" And I walked in the rooms today and I said to every patient, I said, "What can I do to help you live better?" Well, you need to get rid of this pain. You need to get rid of it. So then I said, well, what would you do to live better? You're 345 pounds and your knees are shot. Would you lose some weight? Would you exercise? Would you change your diet? Would you change the things in your lifestyle that are causing this? If you're constantly having bladder leakage because you're constantly drinking caffeine, which is a diuretic, will you change that? What would you do to live better? Because we always think it can't be lifestyle that does it. Do you understand that if everybody that had high blood pressure changed their diet and started to exercise, we'd put the blood pressure medicine people out of business? But they're safe, because we ain't gonna do it. If you're overweight and it's causing urinary incontinence, are you gonna lose weight? Will you lose weight? Will you sit down and simply do what are called Kegel exercises to strengthen the pelvic floor? But see, we think, it can't be that simple. It can't be that simple. But sometimes it is. Lifestyle changes. And then the last thing is advanced therapies. So if we do the lifestyle changes, or we don't do the lifestyle changes, and we try the medicines and they don't work, there are other options that are very, very effective. Here's some of the lifestyle changes that I skipped. Diet, exercise, bowel and bladder retraining, pelvic floor strengthening. Bowel and bladder retraining is interesting because sometimes you can literally use biofeedback to train yourself to not be incontinent. What that consists of is like, if you know you go to the bathroom 8 times a day, and you know the time in between those times, maybe try to go 10 minutes longer. Intentionally. Mentally putting your focus on, I'm going to try to go longer. I'm going to try to control this. Feedback, constantly listening to your body. And it's shown to be effective. But these are lifestyle changes. Pelvic floor exercises. Most women have done Kegel's exercise, especially if you've had a baby. There's something that y'all could be doing them right now. We wouldn't even know it. We wouldn't. Julian's doing it right now. I can't. I mean, she's just doing it. I don't even know. But we decide it can't be that effective. But these are all things we can do. Oral medications, I talked about some of the medications cause dry mouth, blurry vision, constipation. The anticholinergics, that's the other thing they cause. They cause dry mouth and dry vision, but they can also lead to constipation, which sometimes they just can't tolerate. Some of them can lead to hypertension. Here's the thing about these medications. 20% of people who have overactive bladder are extremely satisfied with their current, only 20% are satisfied with their current treatment. So these are people that have been diagnosed with overactive bladder, they're on medications, only 20% are satisfied with it. So if you go to the doctor and they put you on a medicine and only 20% of people are satisfied, you're not going to keep taking it. You're not going to keep going back and asking the same questions. 80% of OAB patients, overactive bladder patients, are not adherent to their medication at 12 months. So this bottom one's pretty interesting. Of people that have OAB, 60% don't return after their first appointment. They go to their first appointment, they're not happy with what the doctor said. Did the doctor listen? Did the doctor do anything? Or did he just say, it's a fact of life? Or are not happy with what they did. 60% either never go back to that doctor again or never mention it again after the first visit. 80% after the second visit, and 90% after 3 appointments. So it's an extremely high attrition rate because people are unsatisfied with it. So it leads to what else can we do? And that's why we're here tonight. What else can we do? There's a number of other things that can be done. A couple of them I'm going to brush over real quickly, but we're going to hit the one that is really where I feel the best treatment is. So some of the other things we do. For bladder control, Medtronic InterStim, we're going to get to that. Medtronic Neurosystem and injected medications, bowel control, Medtronic InterStim, and then there's surgical options for bowel control. So let's talk Botox. I'm not sure I would ever be hard up enough to do Botox in my bladder. Now, I would do Botox in my forehead. About every 5 or 6 months, my wife says, "You look hideous." So she calls our friend that does Botox, and she says, "Jack will be there tomorrow." And so my wife forces me to get Botox in my forehead. It's abuse. But I do it because I don't want to fight, right? But one of the treatments for urinary incontinence in an overactive bladder, when that muscle is constantly firing and constantly squeezing down, is to actually inject Botox into the bladder. Botox relaxes the muscle. It lasts about 3 or 4 months. It works, but it only lasts about 3 or 4 months, and it has to be done repetitively. And sometimes it can lead to a loss of function of the muscle and cause urinary retention. So it's not perfect. It can have its own side effects. And it's not pleasant to get Botox, but it does. And it's a good therapy. The problem is it's not easy to do. You have to come to the doctor's office. We fit you for a little device that straps onto your foot. It's almost like a little stimulator, a little acupuncture needle that stimulates that tibial nerve. It takes 30 minutes, and you have to do it how many times? 12 times. Like once a week for 12. Once a week for 12 weeks. So it's time consuming. 30 minutes once a week for 12 weeks to have this treatment, and then you have to have maintenance treatment. It is effective, but it's difficult. It's time consuming. You're sitting there for all this time, and it disrupts your lifestyle. So you're doing something to disrupt your lifestyle, to fix something that disrupts your lifestyle, but it is an option, it is effective. But here's the one that I'm a big believer in, and this is the one that I do. This is called sacral nerve stimulation. And this one addresses the problem, which is the failure to communicate. So what happens is if you're not getting the signals from the brain to the bladder, either there's too many signals bombarding the bladder and you're constantly getting this stimulation And because of that, you've got the overactive bladder and you're getting leakage, or there's some sort of communication issue, whatever the cause. Maybe it's because in the past you had a stroke. Maybe it's because of this issue. So here's how it works. You come to the doctor, we go over the issues, find out what you've got, we make the diagnosis of overactive bladder, and then we say, what have you done so far? Well, I've been on medications, I've tried to do lifestyle changes, I've done Kegel exercises, nothing's working. So then you're a good candidate for this treatment. Here's the beauty of this treatment. You get to test it out without any kind of permanent implant and see if it works for you. So what happens, you come to my office, we decide you're a good candidate for InterStim. First thing we do is we do a simple little procedure in the office where you come in, we start an IV, we take you back to our little surgical suite where we have the x-ray machine. We give you a little medicine in the IV and sedate you so it doesn't hurt. You don't feel anything, you're still breathing on your own, it's conscious sedation. And we take a needle, look at the x-ray machine, and we guide the needle down to a tiny little opening in the bone in your sacrum where the nerves come through. And we guide this little electrode that you can probably barely see through the needle. And this electrode on the end of it, it's got 4 little connection points. And this electrode goes into that little opening and sits right on top of the 3rd sacral nerve. And once it's in there, we hook it up. We pull the needle out. The electrode comes out of your skin, so this little thing's hanging out of your skin. We hook it up to this little battery, and this goes in a little belt. The belt goes around your waist, and you wear that for a week. And it stimulates that sacral nerve. And we see, is it going to work for you? So you put that on, off you go. Normal activity. No restrictions. The only thing you can't do is get it wet. So you can't take a bath or a shower for that week. You sponge bath. But you do your normal life just with this little belt on. And it's constantly stimulating that sacral nerve. And one of the things, if you listen to that video that Sarah was talking about, she said during the trial, it was interesting. We had to make some adjustments, and it wasn't until the next to last day that she got control. So these guys right here are my Medtronics reps. When we put this in, these guys are your best friend. They're calling you, they're texting you, how's it going? Is it working? And those 7 days, we have 7 days where we can make adjustments. The one mistake, the most fatal mistake that people make with this is that after day 1, if it's not working, they say it's not going to work. And they don't ever make a call. They don't ever tell the reps this isn't working. But if it's not working, if it's not giving you the control you want, you tell these guys, they make some adjustments. And like Sarah, it took to the next to the last day, but it finally worked. We finally got the pattern right and the stimulation right. So after a week, doing normal life, making the adjustments that are necessary, you come into the office and we decide, did this work for you? Did it help control your symptoms? Was there improvement in your symptoms? And if you say there was, and it improved your quality of life, then all we do is I take the tape off, I pull this little temporary electrode out, and we decide we're going to go for the permanent device. And so a week, 2 weeks, 3 weeks, whatever later, once we get approval through the insurance company, you get the permanent device. Permanent device is very similar. Take you into surgery, we give you a little sedation. With this, we put a needle down, that 3rd sacral nerve, we slide the electrode in. The permanent electrode is this one actually because it's got the little anchors on it that once it goes in, it won't come out, and unless we want to take it out. And then once it goes in, we make a small incision. We hook the lead up to this. This is the Medtronics InterStim battery. This goes into the battery. We make an incision at the top edge of your buttocks. We slide this under the skin, about 1 centimeter or 2 under the skin. We close the incision, and everything's on the inside. And this battery doesn't have to be recharged. It works because it works. These are a slam dunk. I've never done a therapy in all my life that worked better than this therapy. I don't have anybody that I put these in that comes back and say, it didn't work. I've never taken one out because it didn't work. They work so good and they're so effective. And if it's going to work for you, you're going to know it because of the trial. And once it's in, you guys can come up afterwards and feel this battery. This battery's tiny and it's thin. You can't even feel that it's in there. You don't even know it's in there. And here's the thing. There's no limitations. There's no restrictions. It's MRI compatible fully. Whole body MRI compatible. You need to have an MRI because somebody's worried about you hit your head or something's going on with your knee or your back. This is not restricted. You can have an MRI anytime. It's an unbelievable therapy, and it actually addresses the problem. It addresses the communication problem between the brain and the bladder because it modifies the signals. So if you're getting constantly too many signals bombarding, and this thing is stimulating, it's interfering with bladder control is improved because it interferes with those signals. The way I was trying to think about it today, I was thinking about like if I'm in this building and I'm trying to communicate with Hannah, and all of you guys are yelling questions at me at the same time, and I'm trying to communicate with Hannah, I can't communicate with Hannah. But if I eliminate some of those questions, if I kind of block that down or turn that volume down, then I can communicate. And that's what the bladder's doing. And there's some super smart people that are way smarter than me. And nobody knows really exactly how it works. But we know it works. And you know, it has something to do with that communication with the brain. But it's incredibly effective. You look at the bottom there, over 80% have achieved success of bladder control at 5 years. 5 years later, it's still in. You have 80% have got bladder control. 5 years in. Incredible therapy. It's MRI compatible, like I was saying. So you have to ask the question, is this therapy right for me? If you're somebody that has overactive bladder, and you're afraid every time you go out, that little imagination I have to start, if that's an issue with your life, if your life is limited because you can't do the things you want to do, because you're in constant fear of having that accident, then this therapy is great for you. And like I've already mentioned, you can test it out, right? It's like if I'm trying to sell you a car, I let you test drive the car and you love it, then you buy the car. With this, it's just a needle stick, you wear it for a week, and off you go. It's not having, you know, I have people that have back surgery all the time, they come back to me because the back surgery, they still hurt. Well, I can't undo the back surgery, but I can undo this. But you never have to because it always works. You've had significant symptoms, you've tried lifestyle, you've tried oral medications, and none of it has helped. And you still have the problem. 84% satisfaction who use it. 84% satisfaction controls their bladder problems. And 80% after 5 years. 3 times greater improvements in quality of life categories. 89% of people using Medtronic bowel control therapy experience long-term success. Nearly 90% of people with fecal incontinence. I've talked a lot tonight about urinary incontinence because it's more common, but it's the same treatment for fecal incontinence. And I've done it in people with fecal incontinence, and it's incredibly successful. So, it's an incredible therapy, and it's very effective, and it's easy to do, and the risks are minimal. So, if you have family, if you have friends, if you have these issues, it's a therapy that's good for you. I don't know if did you guys have, they're going to pass through some questions. First of all, let me just open up. Does anybody here have any questions while we're here?
What is the concern? Why isn't this more common?
That is a good question. And that's an interesting question because here's the deal. It's funny how I got started doing it. I got started doing it because I do spinal cord stimulators for back pain. And one of my friends, who I've known for years, and we've crossed pathways a number of times, worked for Medtronics, and he did. But what I found is that I've got a ton of I've talked about to their doctor, and nothing was done. And I don't really know why it's not done more, because it's incredibly effective. But I don't know if people are just, if doctors just don't know about it, if they're not trained to do it, if they're not comfortable doing it. But because it was so comfortable to me, it's way easier than putting a spinal cord stimulator in. And then once I started doing it and seeing how it affected people, like, yeah, I want to do more of this, because it is, of all the therapies I do, it's the most satisfying.
Is it an insurance issue?
We've never really, now, some of my staff might have to answer that question, but we've never really had problems with insurance happening. I mean, here's the thing that you have to do, and I'll show you. Most of you guys, you all got a packet when you came in. In the packet, in the envelope in the packet, there is there's a couple of things in there that are going to be beneficial for you. One of them is a diary. And a diary is one thing we send into the insurance company to prove, okay, they had this many accidents, they had this many leakages, they had this many. So one of the things the insurance company wants to see is it really overactive bladder? Is this really an issue? Is this really something that's happening? So part of the deal is we have to dot our I's and cross our T's and send in the right information, send in the diary. But people that have had the diagnosis, I mean, I hardly ever remember anybody that was denied insurance-wise, but we do jump through the hoops. And so sometimes we do the trial, and then we have to send in to get the permanent approved. So there may sometimes be a month or 2 months in between that process to get it approved. But it's a good question. I don't know why people don't do it more.
Well, it's frustrating when you're a patient and you tell your doctor
Yeah.
over and over and over, and it's like,
That's the thing, and that's why the stats are that half the people don't ever mention it to their doctor. And here's the thing that I thought about that stat. That's a stat that comes out of a study, and who knows, how they did it. But I wonder how many people, if 50% don't talk to people, how do we know it's not more than that? I mean, I think it's probably more than that. And how many people tell their doctor, and their doctor either says, well, I mean, it's like, if you don't know how to treat something, then a lot of times you just kind of move that out of the way. I don't know if that's a secret that doctors do. I don't know if you knew that. But I always try to think, in my mind, there's always something I can do. And maybe the only thing I can do is sit and pray with you. There's always something you can do. But if somebody decides, I don't really know how to treat that, I don't have the technology, I don't have the know-how, maybe they just move on to something else. It's unfortunate. Any other questions?
Is there any documentation of any kind of side effects to the implantation of this, any risk of infection?
Well, anytime you cut skin, there's always a risk of infection. So that's why it's done in a sterile environment. The trial we do in my office, we use a sterile technique. It's just a needle stick. It's just like getting a shot. But you do have this electrode that's coming out of the skin. We put a barrier dressing on it, and we try to keep you from doing anything silly, like getting in the creek. So I had a guy that we put a spinal cord stimulator in, and 2 days after we put it in, he went swimming in Barren Fork Creek all day, and he got infected. But if you do what you're supposed to do and do what you're told, so there's always a risk of infection when you cut skin. But as far as like side effects, most people that have this therapy, they describe as just kind of some of them feel like a light tingling sensation. Some people don't feel anything. It depends on how high you turn it. Some people like to feel the stimulation because then they know it's there, they know it's working. Some people don't want to feel it. But, I mean, I've never had patients who have had issues with, any kind of problems from the actual implant. Now the batteries, how long do the batteries last, guys?
Up to 15.
15 years or so is what they normally last. I have had some patients that the batteries have gone dead. We go and replace the batteries. But they don't have to be recharged. Spinal cord stimulators, you have to recharge. These are non-rechargeable. You just put them in, you leave them in, and you let them go. Some people, the thing about the untoward effects is if you have the trial and you don't like the stimulation or the stimulation is uncomfortable, you're going to know. And you just say, you know what? Maybe it worked for me, but maybe it was uncomfortable, so I really don't want to put the permanent in. That's the beauty of the trial. You're going to know if you have a bad effect from it while you're doing the trial. Anybody else? Somebody else, I think, was saying something. Let me do this.
Excuse me, sir.
Yeah.
How long have this been in practice, this force, this theory? It's fact now, but how long have this procedure been practiced?
I've been doing it about 10 years. It's 25, isn't it?
1997.
97, so 25 years is when it first came out. I've been doing it about 10 years.
The question was, do it ever misfire?
Well, by misfire, you mean doesn't work for them?
What I mean is misfire, is seeing electrical signal through your spine, and do it ever misfire? I mean, keep your mind confused a little bit.
Well, this one is on peripheral nerve, the sacral nerve in your pelvis. So it's not, I mean, it's about this far from where the spinal cord stops. So it's not going to affect your sensation or your clarity. Now, if you have, maybe some people have a sacral nerve that's more sensitive and they do the trial and they have pain from it, then they're going to know that in the trial and they just don't do it. Now, I've never had any that have had a problem with the battery where there was, the battery caused an issue or the battery caused them to get shocked or anything like that.
So I was saying that you kept saying about 5 years. After the 5 years, you get the procedure, and I want to have you there longer. Would it keep me sterile and don't have to keep?
Well, the 5 years is a study, so that's kind of confusing because that study, they followed it for 5 years and said it was 80% effective after 5 years. But I've had people that have had them in. I've been doing them 10 years. I have some people that have had them for 10 years and they still are very effective. So it will constantly work, as long as the battery's working. If it goes 15 years, you have to get a new battery, it'll still work with a new battery. That 5 years is just a study that was done, that they haven't gone further than that.
I'm good.
Okay. All right, this says, if I have a spinal cord stimulator, can I use this for bowel and bladder concerns? Yes, the answer is yes. You can have that. Let's see. I don't want to break my glass. Can you see the device under the skin and does it protrude? It does not. We put it about 1 to 2 centimeters under the skin. When we're done, I'll let you guys see this battery. It is very small, it is very thin. If you feel back there and you push your fingers on it and feel it, you can feel it, but you can't see it. So it's not something that sticks out, it's not something that protrudes. It's very, very thin. It's smaller than the spinal cord stimulator batteries. How long does it take to get the test? And is it an office procedure? So the test itself literally takes probably 10 minutes of actual office time. It is an in-office procedure. I do in our office, in our back suite where we have a fluoroscope, a live x-ray machine, and we just take you back there. So you would come in, we would start an IV, we would take you back to the back, we'd give you a little IV sedation, and then we just put the needle in, put the electrode down. We test it. Well, one good question that I think is, how do you know you're in the right place, right? So this is the craziest thing about this treatment. You test it to see if it's in the right place. And here's how you know it's in the right place. If you're on that third sacral nerve, when we put that in there and you're laying on your stomach and we stimulate that third sacral nerve, your toe curls and your butt clenches. That's called a bellows sign. And so I've got my rep sitting there and I'm looking at the patient's buttocks. He's looking at the patient's foot. And I touch it to the nerve and I go, got a bellows, got a toe, got a bellows, got a toe. We know it's there. If we get those two reflexes, we know it's on that nerve. We know it's going to work. So it's not like a guess, because sometimes we do it and we put it in and we don't have it. So we know we need to move it. But we move it until it's in the right place. Pull the needle out, hook it to that little white battery, tape it down, or put it in that little belt. And then the patient gets up, so you're in the building for an hour, and off you go on your normal daily activity. So the test is very short, it's very quick. When you come in, usually if I get someone sent to me for urinary incontinence, the first visit is let's talk, let's figure out what's going on. Is it overactive bladder, is it stress incontinence? Let's look at your history and whatnot. If it looks like you're a good candidate for it, we give you a diary to take home for a week. I send off to the insurance company. We get approval, you bring the diary back, and then we set up the test. So usually from the time you would come in the first time to the time we do the test is probably 2 to 3 weeks. And then depending on the insurance company, to put the permanent in, it may be 2 to 3 weeks to 6 weeks. So the permanent is not an in-office procedure. The permanent is in the operating room because we are cutting skin for that. We make an incision about this big, slide the battery in. All the stitches are under the skin, so none of the stitches have to come out. We close the skin with skin glue, put a little bandage over it. You wear that for a week and then we peel it off and you're good to go. It's just that first week you have to keep it dry. And the actual implantation of the battery probably takes 20 minutes. How long does the InterStim battery last? We asked that. 15 years-ish. How big of an impact does this therapy make in someone's life? Of all the therapies that I do, this makes the biggest impact on anybody. Because it's like I've said before, I mean, probably everybody in this room's had back pain or knee pain or something like that. And even with that, you still can go do stuff. You might have back pain and your grandson's playing t-ball and you're going to go and sit through the t-ball game for an hour with the back pain and just try to find a comfortable position and get through because you want to see your grandson or you want to see your son or daughter or granddaughter or grandson dance or play soccer or whatever. But if you can't be sure that you're not going to have an accident and be completely embarrassed because you had an accident at this event, you're not going to go. I'm not going to go. And that's a huge impact on people's lives. And if you can't go out and take a walk or exercise or go to the gym or go do yoga or had a patient today that started doing Tai Chi and loves doing Tai Chi. You can't do Tai Chi because you're worried about that. It's a huge impact. More than any other therapy I do, it impacts people's lives. Does insurance cover the test and the procedure? It does. We just got to cross our I's and dot our T's, make the diagnosis, send in all the right information, and it covers it. What if you don't feel the urge to have a bowel movement until you have to rush to go? That's the thing about this. When you're talking about incontinence, with a bowel movement or with urine, even if you don't feel the urge to go, this still works because part of the problem with this is you're not getting the communication. If the bladder is not sending the signals for the urge to go, then the communication is messed up somewhere, and this addresses the communication issue. So it still works. All right. Sometimes I forget to urinate and don't feel the urge to go. It's the same thing. Any of these urinary symptoms, if it's not urinary retention that's caused by the prostate or by a tumor that's blocking the urethra or a stone or something like that, this is a communication issue with the brain and the bladder. And this addresses that communication issue. So it is effective for that. Any other questions? Yes, ma'am.
If you want to have this done, the trial done, is that done in Muskogee or in Fort Gibson?
Muskogee. Yeah, that's where we have our fluoroscope. So we would do, if I'm doing it, we would do the trial in Muskogee, and then the permanent implant would be done in the outpatient surgery center in Tahlequah. Now, if you were going for your first visit to see, am I a candidate for this? Will it work for me? You could go to Muskogee or Fort Gibson, and you could see me or Julia or Monica or Susan or Ryan or Dr. Elgin, any of the providers. You could see them, and so that could be Fort Gibson, that could be Muskogee, that could be wherever for the first treatment. Anything else? Any other questions? So these packets that you have, they got a couple of different things in them. One of the things in the packet is a handout that talks about the ambassador program, and it's a very effective thing to look into. The ambassador program is, I think it's a 1-800 number, Chance? Yeah. It's a toll-free number. It's on the little handout. It's the handout that's long and narrow. It says the ambassador program on the top. You can call that 1-800 number, and they will link you with somebody who has had this procedure. And they're usually pretty effective at linking you with somebody that kind of fits in your same category, age group, or symptom group, or whatever. So you can literally talk on the phone to people that have had it and find out, here's what it felt like, here's what it took. So that's very effective. It's a 1-800 number, toll-free, cost-free. So that's something if you're thinking, well, no, I'd like to talk to somebody that has had it before. That's a very effective one. There's some other handouts in there. One of them has two QR codes that you can scan with your phone. They're both videos that are like Sarah's video, but are a little bit different people in those videos. There's one that's a fecal incontinence video that we actually have that we didn't want to play, but that's in there. There's also a symptom diary in there where you can look at the symptom diary, and basically it's just a handout that you take home and you look at, and you keep your symptoms on there. And then there's another information page that's a little packet that's about 4 or 5 pages, and it specifically talks about the InterStim device and kind of gives you more in depth on that. You can go on YouTube and put in Medtronic InterStim, and there's a couple of videos, Sarah's videos on there. There's other videos that kind of go through the procedure and talk about that. So there's a lot of information that you can get to with that. Our purpose tonight was to kind of address your question. Why isn't this done more often? And I think it's not done more often just because people don't know about it. And people don't understand how effective of a therapy it is. And it is an incredibly effective a therapy. It's easy to do. It is life-changing. It's a trial that you do first, and then you know if it's going to affect you. And if it works, and it changes your ability to control your bladder, it changes your life. And so it's a therapy that more people should know of, more doctors should know of, more people should refer to. When we first started doing this is when Three Rivers Surgery Center was open, and when the Medtronics people came to me and introduced me to it, and I started doing it. I went to Dr. Sengel and Dr. Ford, who were in town. I said, hey, you guys know about this? And they're like, yeah, but we've never done it. We don't really want to do it. Will you do it? I said, yeah, I'll do it. So they started referring me a lot of patients. But it's, there are some doctors that just don't want to do it, but maybe don't know that it's effective and that it's being done. So I would encourage you, use the information that you've got there, look into it. If you decide that you want to do it, or if tonight you're like, you know what, I want to talk to somebody about it, I want to do it, we have some of our staff at the back table that will make you an appointment and get you in. If you want to get it done quickly, we have appointments available on Thursday. So if you want to get in quickly and say, I really want to talk about this, I want to figure this out, tell them in the back, I want to see Dr. Weaver on Thursday.
I can see you on Wednesday.
Oh, you're going one up. Okay. Julia's back there. Can we get it to, I'll see you right now.
My doctor told me about this 2 months ago, and I've got an appointment with you Wednesday. But I have another question. Is there an age limit? I have a 93-year-old lady that asked me to find that out. Is there an age limit that you'll do this?
If they have cardiac clearance and they're healthy enough to have an outpatient surgery, it's very minor. The trial is very minor. The trial is just like an injection, and we do injections like this on older people all the time. I wish I could remember what the oldest person I did one of these on, but that's if she's healthy and she's, the big deal would be if we ended up doing it and having the actual implant, she'd have to be able to go through, a 20-minute conscious sedation procedure. But there's no other reason why not. If you're 93 years old and you can't enjoy life because you can't control your bladder, why not?
Does the condition that you're treating, whether it's fecal or urinary incontinence, cause other, you talk about side effects, well, sometimes the illness or the disorder causes...
That is a fantastic question. And the biggest side effect that the illness causes is psychological. People suffer from depression, from anxiety. Think about it. If you can't go out and be with your friends, you can't go out and be with your family, it's an incredible psychological effect. So the side effect of urinary incontinence or fecal incontinence is psychological, and we don't look at that. We don't look at the patient and say, well, it's not going to affect you socially or psychologically or your family. That's the biggest side effect. Now, somebody that has, if they have urinary retention like that, I mean, there's a big risk of urinary tract infections. Urinary tract infection is not only a risk factor to cause urinary incontinence, but it's something that can happen with that. Okay, and if you've got constant bladder leakage or bowel leakage, skin infection, skin breakdown is an issue. You know, so there's a lot of issues. The stress of the whole situation. I mean, people that have high blood pressure or have heart issues, if they're constantly stressed about whether or not they're going to have an accident, that can increase their high blood pressure. So everything interplays. But to me, the biggest issue is psychologically. I mean, when you can't live your life, it affects everything about you. Another thing that's a side effect is if you can't get through the night without getting up 4 or 5 times to go to the bathroom, you can't get rest. And that affects you the next day because you're constantly exhausted. You're constantly under stress. So to me, the biggest side effect is psychological.
So you have a psychologist on staff?
I do not.
You need one?
There you go. There you go. It's kind of funny, when I was in medical school, my least favorite class was human behavior. And now it's like my favorite thing to do.
Well, it's so interconnected.
Yeah, everything.
Yeah.
Yeah. Yeah. Any other questions? Yes, sir.
I had colon surgery, removing the tumor, going through chemo, and I have a little incontinence with my bowel. And I don't know if it's just going to be temporary deal and until I get through the chemo or what's going to happen.
The issue with chemo and something like that is the chemotherapy itself can affect the nerves, and it can cause a neuropathy that affects the bowel and leads to incontinence. Now, if it's a short-term deal where it's just, you know, those nerves are going to recover, that's something you never know. But I have had people who have had fecal incontinence and or urinary incontinence from radiation to their abdomen or pelvis or from chemotherapy that have incontinence that we've done this on, that it works very effectively.
I just don't know whether I need to wait till I get through with the chemo and see if everything kind of...
Yeah, I think a lot of that depends on how it's affecting, you know, how it's affecting your lifestyle, and you might talk to the chemotherapy doctor and say, hey, is this something you think is going to recover? You know, but I don't think there's a time limit where you're going to get to the point where, like, if you've waited too long, it's not going to be effective. It kind of comes down to how it's affecting you.
I appreciate it. Thank you.
But the good thing about that is the trial, again, you're going to find out, is it going to work for you? Janet, yes.
Is it Medicaid friendly, or is it going to be like a Medicare and if you have a Medicaid? Or like a younger person that's not quite to Medicare yet?
Trina, have we done Medicaid before? I can't remember. So Medicaid, Medicare, I know Medicare, I mean, that's by far and away the most that we do, but we haven't had issues with Medicaid. And I mean, I don't remember having any issues with any of the insurances, as long as we, you know, you make the diagnosis and you do what needs to be done. The thing about it is, it's so effective. You know, the insurance have a hard time saying, well, it's not an effective therapy, it's an experimental therapy, because it's been going for 25 years and the studies all show how effective it is. So it's really, I mean, it's not one of those deals where the insurance is saying, well, we're not sure it's that effective. Yes, ma'am.
I'm on oxygen. I would like to have this done. Would this be a problem?
You want me to do it right now? I got it right there.
Yeah, I would.
So when we do it, we do, you
Do
know.
I need clearance from my lung doctor? I mean, I would come in Thursday.
Yeah, I mean,
have an appointment ready. I mean, I am done with this. I mean, if I can get some help, I want it.
the biggest issue with the lungs is just, you know, the anesthesia. But I mean, we do people, these type of procedures that are on oxygen all the time.
Yeah.
So that shouldn't be an issue, because we put you on oxygen when we do the procedure. So, you know, depending on the type of lung disease, the anesthesia might say, yeah, we'd like to have a clearance. But what I would do is, we get you an appointment, we get you in, we talk to the lung doctor and get the approval. And, you know, for the trial procedure, it's easy, it's quick. You know, But I don't, I mean, there shouldn't be any reason because you're on oxygen when you do it. Yeah. Tell them in the back you want an appointment for me on Thursday or Julia on Wednesday. Anybody else? Yes, ma'am.
Okay, I just had the, trial for the pain.
Uh-huh.
That trial ended today.
Yep.
Could you have both procedures done at one time?
Not at one time. The insurance would balk at that. But so in your case, we would do the spinal cord stimulator implant and then do the InterStim trial.
Okay.
Yeah. But I mean, there wouldn't be like a long length of time in between. But you wouldn't want to do them both at the same time.
I had a lot less problem this last week. And
With incontinence?
yes,
With the spinal cord stimulator in?
yes.
Guys, we've got a whole new therapy.
Yep.
Well, that's a good sign. Yep. Any other questions? Listen, thank you guys for being here. If you have any questions afterwards, feel free. I'll hang around. If you want to get some more information on it, there's more information at the back table. If you want to make an appointment, we can do that. If you want to talk to any of the Medtronics guys that are here, if you want to see the battery, we'll hang around. But thank you guys for being here. Everybody stay safe tomorrow because it sounds like it's going to be the great blizzard of all time.
Yeah.
Tomorrow, go get your bread and milk and eggs. And again,
If you can afford it.
if you can afford the eggs, you can afford the eggs. You could probably trade one of these batteries for 12 eggs. All right. Thank you guys for being here.